Hello, my name is Dr. Mary Jo Kurth. I'm Director of Business Development at Randox Laboratories, and I'm here today with one of our collaborators, Dr. William McBride, who is Consultant Cardiac Anaesthetist at the Royal Victoria Hospital in Belfast. And we've been working with William for, what is it, William, now? 13 years?
I think we've been coming here. I've been making the trip to Randox now for over 13 years. I've been a regular visitor here on multiple occasions, and we've been working together on quite a number of projects, and it's been a delight right from the very day one since I first heard about Randox and came here. We've been involved ourselves in cytokine research for almost 30 years, and I've been working with various grant support from various bodies. And then I was delighted to learn from someone who later became my wife, that who worked in Randox, in fact. So Randox supplied me with my wife, which was delightful. And I learned from her that Randox was involved in all these biomarkers, and I couldn't believe my ears. I said, right, I need to chat to these people. So I came, and the rest was history. We found that this interaction between ourselves and myself as a clinician involved in the inflammatory response, and particularly in its outcome on renal dysfunction following cardiac surgery, that the moment I was able to actually engage in conversation with the scientists here in Randox, the experts in that field, that interface between that which was clinical and laboratory suddenly became a very productive result, and I think that the outcome has certainly been very pleasing, and I believe is just on the cusp of leading to something which will have real benefit for patients.
So obviously through your work as an anesthesiologist, you see many cases of acute kidney injury. So what is the current issues? How do you diagnose AKI, and you know, where do you see room for improvement?
Well, at the moment we look at our patients preoperatively. We try to determine if our patients have normal or abnormal renal dysfunction preoperatively, and then we monitor their renal function carefully postoperatively, mainly looking at EGFR. EGFR is the one test which we use both pre and post-operatively, and if somebody has got lower than normal EGFR, then they would fall into the category of chronic kidney disease preoperatively. But most people come along with a normal EGFR preoperatively, and then post-operatively we monitor their EGFR immediately post-operatively and every 24 hours thereafter. If there is some renal dysfunction appearing, then we would take more often measurements of their plasma creatinine levels and associated EGFR measurements. But the main plank for diagnosing the problem is, from the laboratory point of view, looking at EGFR. Then there are the clinical measures as well. We're obviously concerned if the urinary output is falling off, if potassium is rising in the blood, if there is fluid overload, and most importantly, if the patient is becoming acidotic. Certainly in the cardiac surgery context, acidosis is very injurious to the myocardial function, cardiac output, and overall body perfusion. So the main way that our patients get into trouble with an evolving acute kidney injury is due to the impaired total body perfusion, due to impaired myocardial function. That's the first one. And secondly, we will end up with a degree of fluid overload. Now, I'm not worried about fluid overload in the feet or in the hands, but certainly if you're going to get pulmonary edema, that can really cause a problem, and that is a very significant issue as well. The potassium we can easily deal with by virtue of an insulin dextrose infusion. The acidosis we can temporarily hold off by virtue of a bicarbonate infusion, but fluid overload, once that's happening, may require prolonged ventilation. If the patient, we're trying to wean the patient from ventilation, that can become a problem. But let's bear in mind that one of the important functions of the kidneys is actually to clear the blood of those pro-inflammatory mediators, which we know are majorly increased during perioperatively at cardiac surgery. So if the kidney starts to fail, then one of these key anti-inflammatory mechanisms which the body employs, which is to filter out those smaller pro-inflammatory mediators, which are mostly less than 20 kilodaltons. Once we lose that, then we get a build-up of these pro-inflammatory mediators in the blood. We call that, we call the safe levels of pro-inflammatory mediators in the blood, we call that safe cytokine capacity.
Right.
In an editorial in the British Journal of Anaesthesia almost 20 years ago, I described that safe cytokine capacity. And systemic safe cytokine capacity, I think, was the phrase we used. And why is these pro-inflammatory mediators allowed to be increased, and yet that is safe? The reason it's safe is because this is balanced by a concomitant anti-inflammatory response in the blood. Now, this system works provided the kidneys are able to remove those pro-inflammatory mediators consistently, quickly, and efficiently to avoid our safe systemic cytokine capacity, which is made up of the anti-inflammatory mediators, to prevent this system being overwhelmed. Now, once we get an acute kidney injury, guess what happens? The system gets overwhelmed. There is nowhere for those pro-inflammatory mediators to go, and they will accumulate. And this will not only lead to further injury to the kidney itself, which it will cause, but it will also lead to a global capillary leak phenomenon developing. And we end up with, and I'm not worried about global capillary leak leading to puffy hands or puffy feet or even puffy conjunctivae, but you can rest assured of one thing: once you get puffy lungs, that's pulmonary edema. And once the kidneys start to go down, then the other organs start to fall like dominoes, because our ability to remove and siphon off those pro-inflammatory mediators is taken from us, and then we get into other troubles. So acute kidney injury isn't merely a problem affecting the kidney, because we can solve that with hemodialysis even, but there's a lot of collateral damage as well affecting the lungs. Then the lungs, you get pulmonary edema, the lungs get wet, and when you've got wet lungs, guess what you get? You get a much higher risk of lower respiratory tract infection. And then you're into the significant prolongation of time in the ICU with the added expense and difficulties that will entail both for the patient and the care provider.
Okay, so you mentioned about the pro-inflammatory and the biomarkers, but what is the biomarker that is measured routinely?
We don't measure a biomarker routinely to assess inflammation. The only one which we do is CRP, which is very much a blunt instrument in our institution. Okay. And it goes up anyway in our well patient, whether you're low risk or high risk, up goes your CRP. But we have nothing more sophisticated than that. And yet, which is a little bit sad, bearing in mind that we know that key elements involved in the pathogenesis of multiple organ dysfunction, in fact, is the pro-inflammatory response and balance, or perhaps more accurately, lack of balance with the concomitant anti-inflammatory response. And it's just a shame we're not routinely measuring these things.
Okay, so whenever we first met, it was many years ago, you highlighted this issue to ourselves, and we came up with a plan to investigate, I think, was it over 30 biomarkers in samples taken pre and post cardiac surgery?
Well, that is right. You come up to me with you offered me all these biomarkers that you could measure. Now, you were able to measure absolutely everything that I wanted to measure, but in addition, you come up with another 30, some of which I'd never heard of before, but I've since had to become familiar with them. And this was just like entering an Aladdin's cave with biomarkers. This was just wonderful, because we got representatives of the three great giants, which I like to talk about: the giant of hypoperfusion, the giant of ischemia-reperfusion, and the giant of pro-inflammation. And I got more than I could wish for in terms of potential biomarkers here. And whenever you looked at all these, and we started a big study in cardiac surgery patients, later orthopaedic surgery patients, then with your expert statistical advice here in Randolph Laboratories, we were able to subject all this to logistic regression analysis. And very satisfyingly, for me at any rate, representatives of the three giants, biomarkers which represent the three giants, jumped out at the very top of the pile of markers which were predictive of acute kidney injury post-operatively and also with a strong signal preoperatively. So this illustrates, I think, whenever an understanding of the pathogenesis was combined with the clinical scenarios and how the clinical scenarios could feed into the pathogenesis, then we're able to get something which is directly clinically relevant and applicable today.
That's great. And so the biomarkers that we identified pre-surgery were the soluble tumour necrosis factor.
Yeah, soluble tumour necrosis factor, it came up preoperatively as one of the preoperative markers. Now, this was a little bit counterintuitive to us at the start because we knew that the soluble tumour necrosis factor 1 and 2 are the anti-inflammatory chaperones of pro-inflammatory TNF. Now, perhaps a word of explanation here is that TNF alpha, being so very small, is readily filtered out the glomerulus. Work by Chatterjee in Edinburgh, or was Aberdeen, showed that work by Chatterjee in Scotland showed that this is directly injurious to proximal tubular cultures in vitro. And if you put the TNF directly onto the proximal tubular cultures in vitro, this leads to necrosis of these monolayers. So it seemed really amazing to think that the kidney is sacrificing itself, or so it seemed, for the greater good of the body in terms of allowing these small pro-inflammatory mediators to be filtered through, unaccompanied by their larger and less easily filtered anti-inflammatory chaperones. And it was at that point that we sort of stumbled over this other discovery, that the kidney is able to generate in itself a massive urinary anti-inflammatory response, which is another story. But the other significant finding we made was that we've just really figured this out, that the blood anti-inflammatory response is a very faithful representative of the underlying pro-inflammatory response which drives it. Now, this is why I said it seemed counterintuitive that something which was anti-inflammatory in the blood would actually reflect acute kidney injury later, because one would have thought that the blood anti-inflammatory response ought to prevent an acute kidney injury. And that's what we originally thought. But when we sat down and thought about the pathophysiology, it became rather obvious the reason why this was, why the blood anti-inflammatory mediators actually were reflective of an acute kidney injury. Simply this, that the blood pro-inflammatory mediators, which drive the anti-inflammatory response, the pro-inflammatory mediators are selectively filtered and they enter the tubules, whereas the blood anti-inflammatory mediators, by virtue of being bigger, are not able to exert their protective effect directly inside the tubule. They're locked out, while their nasty pro-inflammatory mediators are allowed in. So that is why the blood anti-inflammatory mediators, in fact, reflect the underlying pro-inflammatory response which drives it, without in itself providing a protective mechanism. Once we realize that the blood anti-inflammatory response is not protective of the urinary pro-inflammatory mediated, of the renal pro-inflammatory mediated injury, then we can understand logically how the blood anti-inflammatory response is in fact reflecting the magnitude of the pro-inflammatory response which drives it. And that's why that floated to the top in our logistic regression model as being an excellent biomarker predicting acute kidney injury. And the other feature is, which is very, very important, by virtue of being so readily filterable by the glomerulus, the smaller pro-inflammatory mediators, they disappear from the blood, and thus are very, very hard to measure, whereas the larger anti-inflammatory mediators, by virtue of being retained in the blood, are very, well, relatively easy for our Randox experts to measure, and therefore that becomes a very faithful indicator of an underlying pro-inflammatory response, which if you blink you miss it, but the anti-inflammatory mediators are a very faithful reflection of that which we can actually quantify and measure, and that is why that jumped up to the very top of some of our logistic regression models.
Mm-hmm. It's not the case that the TNF-alpha is very difficult to measure, but soluble tumour necrosis factor 1 and 2, they're normally membrane bound. But in the case of the inflammation, they're released into the bloodstream, so they're soluble tumour necrosis factor, and we believe they're mopping up the TNF-alpha.
Well, I believe that's absolutely the case, and whenever you get a transient blood pro-inflammatory response occurring, that occurs briefly. It's quickly removed from the scene by virtue of the kidneys, but the anti-inflammatory response seems to have a long memory, and it swings into action and stays elevated for a significant period of time. And this shows us the mechanisms within the body to protect against the injurious effects of a pro-inflammatory response. And the interesting thing is, and this is work done by others, that patients who have chronic kidney disease have a higher constitutive baseline level of blood anti-inflammatory mediators. And this may well explain why our patients who have chronic kidney disease, whom you might expect to get into dialysis-dependent renal failure, in fact, quite often they don't. And I can think of quite a few occasions, some patients who stand out in my memory for whom I had a solemn talk preoperatively, explaining to them due to their chronic kidney disease, you're at real risk of being on dialysis for a while afterwards. They flew through the surgery and this didn't happen. And this is because they have these constitutive, very effective additional anti-inflammatory mediators present. And in that editorial in the BJA way in the early 1990s, we floated that concept. Not in the early 1990s, sorry, in 2004, early 2000s, we discussed that concept.
And then in the blood sample taken 24 hours post cardiac surgery, the biomarkers that the software pulled out of the 30 was soluble tumour necrosis factor 1 or 2, and then heart type fatty acid binding protein and midkine.
Well, again, this wasn't unexpected, because these markers really, that aspect was not unexpected. The tumour necrosis, the soluble tumour necrosis factors, anti-inflammatories, was initially surprising to us, but I think we've got a very sound and scientifically plausible explanation of why that works so well once we understand the physiology of filtration of the tubules. But we were very delighted, and this confirmed our hypothesis that the midkine and indeed the HFAB were identified as assisting our logistic regression model very effectively. Now, all of these added to our logistic regression model, all three representative of each of the three giants of hyperperfusion, ischemia reperfusion, and pro-inflammation. 3 seem to operate much better in the model than 2 or even 1. So taken as a combination of 3, we get much better area under the rock curve in sensitivity and specificity. And this shouldn't shock us, because we've got representatives here in our biomarkers of the 3 giants, which you understand from the pathogenesis of acute kidney injury, are contributing to that pathogenesis phenomenon. And the beauty of this is that our biomarkers, which are models selected for us, I didn't select them, Randux didn't select them, the statistical package lifted these up and presented these to us as the key indicators of acute kidney injury. It all fits in with our understanding of the pathogenesis.
Mm-hmm. So in parallel doing the work, looking at the biomarkers in cardiac surgery patients, you also looked at them in orthopaedic surgery patients.
Well, we did indeed, and we really wanted to put these biomarkers, which we've now come to know a little bit more about, we wanted to give them a real good challenge. Because in the cardiac surgery patients, they started from a baseline of no pro-inflammatory activation preoperatively, because they were all elective low-risk cardiac surgery patients. Okay. Whereas the orthopedic surgery patients, most of them had hip fractures. They had had a fracture and possibly waited maybe 24 hours or more for that fracture to be definitively treated surgically. This meant that they had been preconditioned to some extent by virtue of the coagulation disturbance caused by the fracture. And this was therefore a more difficult challenge for biomarker technology, we thought, because the delta change from baseline to post-operative peak response would, we thought, be less. And in the event, that proved to be the case. But the question was, would that smaller delta change from baseline to post-operative peak still be useful, still retain utility as a biomarker agent? And in fact, to our pleasant surprise, it proved even more effective. Yes, it was very effective in cardiac, but it proved impressive, particularly post-operatively in the orthopaedic patients. Now, we think, therefore, that this means that our biomarkers have application not merely in cardiac, not merely in orthopedics, but in other major surgeries, such as vascular, possibly even neuro, certainly abdominal surgery. It has widespread application in those fields.
That's great. And do you see what, obviously this is something new and something different, so what would be the benefits to people like yourselves using this panel?
Well, the benefits are phenomenal, I believe. Even to the non-clinicians in the team who are involved in planning, staffing and resources, this will be useful. If we know a patient is likely to go into an acute kidney injury, well then the managers involved in running the intensive care unit should be able to assign that patient to more bed days or more anticipated bed days than another patient. Mm-hmm. This will affect scheduling of our patients in a more efficient way. In addition, in the multidisciplinary team discussions taking place before the patient goes to surgery, whenever the surgical pathway is being determined, this information will be useful to help us to maybe advise a patient to which would be the optimal pathway for them to go. Mm-hmm. For example, if you knew you were at high risk from your biomarker preoperative panel of acute kidney injury, then you may wish to go for less invasive surgery such as TAVI, or minimally invasive cardiac surgery such as mini sternotomy or anterior right thoracotomy access for aortic valve replacement. And here's an interesting one for you. If you're about to have a war, mm-hmm. and you're about to send your brigade to some hostile territory where they're likely to sustain a lot of injuries, would you really want to send your soldiers who you have preoperatively screened to be at high risk of kidney injury to that high risk field of military service? I think there could well be application in military medicine in this as well. Okay. Because of the preoperative signal that we've identified.
So you say it's very important then to screen your patients before?
I think it's important to screen patients. So I'm talking about screening. If you're screening a patient preoperatively that you know post-operatively is going to be at high risk of acute kidney injury, it may well push you along the direction of a less invasive surgical approach. Number one, it may enable you to take intraoperative protective measures such as running the patient on a higher hematocrit, running the patient on a higher perfusion pressure perioperatively than perhaps what the surgeon ordinarily may feel comfortable with. It may influence you into perhaps not giving that patient gentamicin or a nephrotoxic antibiotic intraoperatively, and certainly post-operatively you will want to avoid nephrotoxic agents such as, for example, ketorolac mm-hmm. In a patient who is at risk of acute kidney injury afterwards. Now, I love ketorolac as a drug, it's wonderful, but I certainly would not like to give it to someone who's at high risk of acute kidney injury. Okay.
And then post-surgery, you would run the panel again. And what other complications can occur post-surgery with, you mentioned hemodilution might cause an issue?
Well, yes, post-operatively, that's when we really feel the acute kidney injury, when it comes out to bite us post-operatively. It doesn't usually happen intraoperatively, though it can, but it's usually post-operatively in the 12 to 24 hours post-operatively, or maybe even 48 hours post-operatively that this happens. But usually there's a honeymoon period of maybe 12 hours afterwards, whenever the urea and creatinine are perfectly normal. And that is because, due to hemodilution perioperatively, the EGFR is artificially inflated.
Right.
And this is unfortunate because we may feel very reassured at this point, give the patient their non-steroidal anti-inflammatory, and in fact be causing injury to our patient by so doing. But if we get an early indicator at that point that our patient is at risk of acute kidney injury, then we may wish to modify our management accordingly, run them on a higher perfusion pressure than we ordinarily would, run them on a higher hematocrit than perhaps we ordinarily would. We might also think twice about giving them too much clear fluids.
Right. During the surgery?
Yeah, because during the surgery, if we are immediately post-operatively, if we give the patient clear fluids as the preferred fluid post-operatively, that will be filtered at the glomerulus.
Yes.
And that's fine, does the patient no harm normally. But if you've got a patient who has a big inflammatory response, and that can lead to a tendency towards hypotension, number one. It can lead to a little bit of sludging of blood in the microcapillaries of the kidney. This then will reduce oxygen delivery to the critically ischemic part of the kidney, particularly the kidney medulla, where the loop of Henle is dipping in and coming up out again. And you say, well, so what? Why is that a problem? Well, if you've got in a hypotensive patient or one who's got microcirculatory disturbance due to pro-inflammatory response, if you have in that circumstance reduced oxygen delivery to your kidney, the last thing you want is to require of that patient an increased oxygen demand. So where you've reduced oxygen delivery, you do not want to have an increase in oxygen demand. Now, if I give my patient clear fluid, that's going to be filtered by the glomerulus. And this is therefore going to require our proximal and distal tubules, and indeed the loop of Henle, to be involved in the reabsorption of a lot of that filtrate, particularly the salt, and indeed the fluid as well. And the net result of that will be that we are requiring an increased oxygen demand. So when you give your patient clear fluids, there's going to be an increased oxygen demand. You don't want to do that in the presence of reduced oxygen delivery for the reason I've just described. Therefore, if you want to give a volume expander immediately post-operatively, if your biomarker tells you that that's maybe not a good idea, if your biomarker tells you that there's a pro-inflammatory problem biting at this patient's heels, I think you might want to go for a more expensive volume replacement, such as albumin.
Right.
But albumin is more expensive by a long way than clear fluids.
Okay.
But the biomarker, that early biomarker, would enable you perhaps, this is only my personal view, I can't quote a study in this, but this is the way I personally would look at it until we have a study to prove this. I think I could justify the more expensive albumin immediately post-operatively if my biomarker says, hey, we're at risk of impending acute kidney injury here. I say, right, very well then, thanks for that information. I'm going to ask the kidney to do less work at this point, and I'm going to give something that will stay in the kidney, stay in the circulation, namely albumin, which is a more expensive solution, but I can justify that cost by virtue of my biomarker test.
Okay, that's interesting. And then, so when you measure the biomarkers, and you talk about things where we've got a biomarker risk score, and then we've got a clinical risk score as well. How do you see those working together?
Well, the thing about the clinical risk score is this: there's some things you can't do anything about. Sadly, I regret to say you can't do anything about your age. If I had my wish, I'd be 20 years younger. But I'm afraid we can't do anything about that. That fits onto the clinical risk score, I'm afraid. A BMI, you might be able to do something about that, but that also fits into the risk score, and also diabetes. And again, very few of us are able to do much about that either. There's some that fits into the clinical risk score now. the risk score is divided into 4 categories of risk, and we can see that that's been published in our papers. And when we take the biomarker risk score and the clinical risk score together, we have 4 categories. Category 1 is low biomarker risk score, low clinical risk score. Then category 2 is a category.
So we'd have the biomarkers be positive, wouldn't they?
Yeah, where are the risk score? Yeah.
Is that it there, the biomarkers are?
Oh, yes. Category 1 is negative for biomarker risk score, then low for clinical risk score. Category 2 is slightly higher category of risk. It's negative for the biomarker risk score, but high for the clinical risk score. And then the category 3 is positive for the biomarker risk score and low for the clinical risk score. And category 4, positive for the biomarker risk score and high for the clinical risk score. Now, you can read the details of that in the paper, but what for me is the most interesting category is category number 3, because it's positive for the biomarker risk score, but it's low for the clinical risk score. Now, that's a very interesting group, because that's the group that we want to find out about, because that's the group that we have no idea that they're at risk.
Okay.
And they fit into assigned to higher risk management. And I think that is where the Randox kidney dysfunction test comes out on its own. And assigning to higher risk management, what do we mean by that? Well, number 1, the patient wouldn't be on the fast track pathway. Number 2, would not be getting nephrotoxic agents such as particular antibiotics or non-steroidal anti-inflammatories. And we would therefore retain their arterial artery monitoring or central venous pressure monitoring. I personally would try to make sure that we cut back on the clear fluids that we give them, because we're increasing renal oxygen demand in a context of perhaps impaired or compromised renal oxygen delivery. And there are various other interventions that we might make then, which I can't really talk about because we haven't got a published study yet to prove their effectiveness.
That's great. So how would you see it, the kidney dysfunction test being used clinically?
Oh, well, I would love to see this being used preoperatively prior to the patient being considered the multidisciplinary team meeting. That's preoperatively. I'd like that this information being available to the surgical team and indeed the cardiologist to determine the pathway for the patient to go. Is going to go for invasive cardiac surgery or for a less invasive route such as TAVI. I would like, as an anesthesiologist, to be made aware of this so that I can know, should I be running this patient on higher blood pressure? Should I run them on a higher hematocrit intraoperatively? And post-operatively, if I know that the patient is at high risk, let's say category 3, where they're positive for the biomarker risk score and low for the clinical risk score, I'd be cutting back my clear fluids, because I know that in that situation I'm actually increasing the workload of the kidney in terms of renal oxygen demand in the context of a compromised oxygen delivery. In that situation, I would be reaching, now I don't have a study to tell you about this, but personally, based on the pathophysiology, I'd be reaching for albumin in that context.
Okay, that's very interesting. And also, this helps very obviously with the clinical team, but the benefits for the patient?
Well, I think the benefit of the patient is preoperative conversation. Patients ask us, and diligently they ask us about the risks, and we're very open and honest and try to tell them about the risks. If I knew a patient was at high risk of acute kidney injury afterwards and of dialysis afterwards, I think the patient has a right to have this explained to them in the context of candour, and we're all in the same team, in the context of candour and decision making of which the patient should be intimately involved. And not every patient may wish to have dialysis afterwards. That should be included in the consent of the patient if we think there's an increased risk of that. But above all, I think if we can somehow allow greater understanding of the risk of our patient in facing up to this complication, then only then are we in a position to apply strategies to intervene to try to stop this happening. Now, the difficulty at the present time is there are no clearly demonstrated strategies for turning away acute kidney injury in the immediate post-operative phase. I would say not yet.
Okay.
And the reason why not yet, that we do not yet have such interventions or no consensus as to an intervention at that point, let me put it this way, no consensus as to intervention at that point is quite frankly because we're not able to select out those who are actually low risk with respect to clinical risk score, but high risk with respect to the biomarker risk score. Mm-hmm. And thus, that's the group that we're after. As category 3, those who are low risk, in other words, we have no other clinical condition to alert us to a problem, but there is a problem nevertheless, which only the biomarker risk score can tell us. And that's the subpopulation that the interventive studies should be done on in order to see what's actually going to bring about an effective strategy. So in the meantime, I treat these patients in the absence of that facility to us. I'm treating patients based on my knowledge of the pathogenesis, which is one reason why I've used the strategies I've already described. But I believe this is leading to the future. And yes, we have ideas for future research of interventive strategies, which I can't yet talk about, but we believe that they will be application of the pathogenesis, which we have elucidated so clearly over this past 25 years. And we think we can intervene here, possibly in the select group, which the biomarker risk score will pick out for us. They're the ones we want to help. They're the ones who need help. They're the ones who need the future research. And we can't do future research in a blind way. We're no longer blind any longer. We once were blind. We called the renal blind spot, that 12 hours post-op. That blind spot's been taken away. We've now found our vision. And now I think this is a breakthrough upon which more breakthroughs can then be built.
That's fantastic, and we are delighted working with you, and we're very impressed with the results, and glad to say we now, with your assistance, have developed a biochip panel that has the 4 biomarkers that can be used pre and post surgery for lots of different surgeries where AKI could develop, and we're still working with yourself. And so the kidney dysfunction test is at the next stage of the service delivery. Do you want to tell us a few words about that? That's to get into clinical practice. Well,
just say at the personal level, having been involved in this since 1995, and that's almost 30 years later, I haven't retired yet. It's a matter of great personal pleasure to see that all that work, which was done really observational, blue sky research, is now turning into something which is really significant and very exciting. So I just can't wait for that beautiful machine, which I've had sight of, will be coming to my own unit here in Belfast. The arrangements to try to get that set up within our unit are now well underway. And we're just looking forward very much to continue in the service development, Mary Jo. And a huge thank you to you and your lovely team here. I've been trotting up here many times, and it's been lovely just talking through the research, just grappling with the pathophysiology. And together, I think, we've been able to accomplish much more together than we could have if we'd been individually trying to sort this out. So it's been a joy, and above all, it's all about patients at the end of the day. I have to talk to the patients, I have to talk to the relatives, and it just makes such a difference when we know that there is this new development just coming around the corner for something which has been an intractable problem, which has been baffling us as clinicians for many decades. Now we see something just coming around the corner to help us, and it's wonderful, and 1,000 thanks to you and to Randox for the fantastic contribution you have made for patients not only here in Northern Ireland, but I believe globally.
Well, thank you, William. That's very kind, but we need to thank you, because it's only when people like yourselves bring these clinical challenges to us that this will drive our research and continue to drive our research to make sure that the work we're doing is benefiting yourselves, clinicians, and also individuals. So thank you. You are driving the research forward.
Well, thank you very much. My pleasure.